Today we will be discussing about radiolucent lesions of the jaw, part 2. In part 1 we have discussed about odontogenic lesions, which included radicular cyst, cystic lesions, radicular cyst, residual cyst, dentigerous cyst and odontogenic keratosis. Today we will be reading about non-odontogenic cyst. In this we have 3 cysts: Stepney cyst or static bone cyst, simple bone cyst, Nasopalatine duct cyst. These are all cystic lesions, non-odontogenic cyst. First, coming to Stepney cyst or static bone cyst, it's an unilocular cyst at the angle of the mandible behind the third molar tooth below the inferior alveolar canal. Third molar tooth below the inferior alveolar canal at the angle. What is this? It's an aberrant submandibular gland or fat. Okay. Coming to simple bone cyst, it's also called as solitary, traumatic or hemorrhagic bone cyst. It's seen mainly in less than 20 years age group. Female has more predisposition than males. Site, posterior mandible is the most common site. It's like well-defined radiolucent lesion. It's get extended between, this is the root of the teeth, root of the adjacent teeth, it gets extended, is forming an superior scalloped margins with the preservation of lamina dura. Okay, this is a simple bone cyst. Coming to nasopalatine cyst, it's also called as midline maxillary cyst, anterior midline palatine cyst, incisive canal cyst. Here we have a section of the maxilla. There is a palatine process of maxilla. We have a fissure here. This is transverse palatine fissure and this is median palatine fissure. This is the alveolar process. This is a palatine process and this is a palatine bone with greater palatine foramina and lesser palatine foramina. Here we get 4 types of cyst. One is globulomaxillary cyst, nasolabial cyst, median palatal cyst and nasopalatine cyst. The one we are reading now is nasopalatine cyst. It's round to ovoid, well-defined, corticated lesion above the roots of central incisors, resulting in divergence of roots with vital teeth. There is preserved lamina dura and periodontal ligament space. This is the nasopalatine cyst. So, non-odontogenic cyst, 3 cysts you have to remember: Stepney cyst, simple bone cyst and nasopalatine cyst. Coming to odontogenic lesions, now we are going into solid tumors. In that we have Ameloblastoma. It's a benign lesion but it's locally aggressive. It can be 3 types: Unicystic Amyloblastoma, extraosseous or peripheral type, or metastatic type. So it occurs in 4th to 6th decade. It arises from the enamel forming cells of odontogenic epithelium. So it's a radiolucent lesion. It has a buccolingual expansion. So types of Ameloblastoma, we have unicystic type, we have multilocular type which gives a soap bubble appearance, we have solid type with honeycomb appearance, and we have spider web type. So location: posterior mandible, the posterior body and ramus is the most common site. It has a buccolingual expansion with cortical thinning, breach. Accompanying teeth there is displacement and resorption. So what is the use of CT and MR? For delineating the internal cystic and solid components, to see the cortical breach, any soft tissue extension, relationship to the inferior alveolar canal and enhancement pattern of the solid component septation. So we do a CT and MR. So one of the differential diagnosis, odontogenic keratosis. In ameloblastoma there is buccolingual expansion. In odontogenic keratosis there is anteroposterior expansion. Normally the cystic component T1 is low and T2 is bright, but here the cystic component T1 is bright and T2 is low to high signal. Solid component there is restricted diffusion. In cystic component there is restricted diffusion due to viscous contents. Coming to unicystic variant, it has a benign biological behavior. It occurs in the younger age group, and cystic lesion, it can with or without luminal or mural solid enhancing component. Extraosseous or peripheral ameloblastoma, it involves the buccal mucosa, lips, palate, floor of the mouth, tongue base. metastasizing or malignant type, the tumor which shows distant metastasis, but histologically when you say it's a benign type. So ameloblastoma, we have a cystic component and a solid component which have a buccolingual expansion. Cystic component, they have low signal intensity on T1 and bright signal intensity on T2. Solid component, it shows restricted diffusion. So one we have to remember is it has an buccolingual expansion. It causes cortical thinning, there will be cortical breach. The accompanying teeth, there will be displacement and resorption.